0, because in this case you have perfect alignment and all the force will be directed towards the coronary. And finally, deep engagement. How do you do deep engagement? For RCA and LAD, after you have engaged the artery clockwise and gently push in order to make the catheter advance slowly and progressively, whereas for the circumflex, after you have engaged the artery, you have to counterclockwise and gently push. Now, when we select our catheters, there are two variables that we have to consider: the shape and the size. So there are many catheters with different shape, but don't be scared about these slides, because with two catheters you will be able to do almost 100% of non-complex procedure. With XB or EBU catheter for the left coronary arteries, and with the Judkins right catheter for the right coronary arteries. Then you have the Judkins left, which has less support than the EBU, but you can use it in selected situations like ostial left main, or in cases you have to do a PCI in patient with TAVI. Then you have the Amplas family of catheters, and you use these catheters when you need strong support, and therefore for complex procedure, or when you have to negotiate anomalies of coronary arteries, so the origin of coronary arteries. Then you have to select the size, and you have guide catheters that goes from 5 French to 8 French. So this is the default catheter in our practice for simple procedure, which is the EBU catheter. Now that you have understood basic principle support, you understand why, because it provides coaxial intubation, provides better support and stability due to the large area of contact between catheter and contralateral aortic wall, allows precise control and manipulation, laxo bands. Now that we have selected the shape of the catheter, what about the French of the catheter? Now, of course, we have shown that the larger the catheter, they have the support, but you have to negotiate this variable with the fact that these catheters are associated with an increased risk of complication. This is a large observational studies with more than 100,000 patients, and virtually all complications were increased with larger ball catheter, in particular contrast-induced nephropathy, vascular complication, major adverse cardiovascular events. So, but there are situations in which you really need to use a large bore catheter. Like this case that I'm going to show you, this coronary angiography was done in spoke centers, and you see that there is a severe lesion of the left main and severe lesion of the left anterior descending artery. You see here, this is our left main, and then there is tight lesion of mid-LAD. LAD is calcified all the way down to the apex. And this is the spider view in which you can appreciate better the disease of the left main involving the ostium of the circ and the ostium of LAD. Now, this procedure was attempted in this spoke center, but it was doomed to fail, and you understand why. They used the radial approach. They used 6 French 3.5 EBU catheter. They wired the LAD, but they were not able to finish the procedure because no balloon crossed the proximal part of LAD, and therefore this patient was referred to our center. So we actually totally changed the planning of the procedure. We used the femoral approach, which is the approach that gives you the strongest support. We use an 8 French EBU for catheter, and you see that notwithstanding this approach, the 1.5 millimeter balloon was really not able to progress down to this point. This point, with the strong support of the 8 French catheter, we did rotablator of left main and then of LAD down to the apex. Then we prepare the lesion with a non-compliant balloon and stenting the left main, and this is the result after stenting the left main. And then we approach to the left main lesion using a T-stent technique because the angle was favorable to this technique. So we placed a stent at the ostium of the circ and the stent in crossover from left main to LAD. Then kissing balloon, pot, and check with IVUS to assess the proper expansion of the stent, and you see that we were able to have a very nice result, both to the left main and to the LAD. So let's see what you can do and what you cannot do with, according to the French of guiding catheter. With a 5 French catheter, you can do POVA, drug coating balloon, scoreflex balloon, most coronary stents, rotablator with both sides of 1.25 millimeter, some IVUS catheters, kissing with small profile balloons. With 6 French, you can do standard angioplasty stenting, some bifurcation PCI, kissing with small profile balloons, but not bigger than 3 millimeters per balloon. So if you have to do kissing balloon with 3.5 and 3 millimeter balloon, 6 French is not good. You can use flexotome cutting balloon, 6 French thrombuster or export catheter, rotablator with bush size 1.5 millimeter and IVUS catheter. With a 7 French catheter, you can use simultaneous 2 rapid exchange balloon, simultaneous 2 stent deployment. So if you have to use a 2 stents technique, a double barrel stent technique, you can use 7 French catheter, even though I prefer to use 8 French catheter, simultaneous 2 microcatheters. You can use 7 French thrombuster, rotablator with both sides of 1.75 or 2 millimeter. With 8 French catheter, you can use simultaneous 2 over-the-wire balloons or rotablator bar size of 2.25 millimeters. So let's see other cases. Here we have again severe lesion of the left main, but now it's not left main itself, but the ostia of the left anterior descending artery and the circumflex artery. Now the problem with this case is that there is a huge discrepancy with between left main and either LAD or circ. So left main is almost 5 millimeters, LAD or circ are no more than 3 millimeters. So this is another view, and again you see that there is a very tight lesion at the ostia of LAD and circ, and a huge discrepancy between cells and the left main. An epicranial view in which you can appreciate the severity of the lesion. So the only thing you can do here, in our opinion, the best way to deal with this lesion and to address the discrepancy between the left main and the vessel stemming from the left main is a double barrel technique. We inflated 2 stents, first LAD, then circ, and then both together. And this is the final result, which is good. Then we perform IVUS. We are in the LAD, and now we are in the left main. You can see both stents nicely opposed and well expanded. Now, the jack-ins compared to the AVU gives you less support, but as we said before, the jack-ins may be useful in some selective situation, like in ostial left main lesion, which there is no need of support and in which you can avoid deep engagement, which can dissect the left main. Another situation in which it may be useful to use a jack-ins catheter is after TARI. Jack-ins left comes in measure that goes from 3 to 6, and they differ in the length of the last part of the catheter after the bend. So if the tip of the catheter is down the left coronary ostia, it means that it's big. If the tip is up, it means that it's small. So in case you have short left main and you have to do selective hooking of LAD or circ, there are some tips and tricks that you can follow. If you have to go towards circ and for posterior, counterclockwise the catheter, or use a bigger catheter. If you have to go towards LAD, therefore anterior, clockwise the catheter, or use a smaller catheter. But there are also some maneuver that you can do to modify the catheter. So you do this maneuver if you want to go towards LAD, so bend the tip towards you. For this other maneuver, if you want to go to the circ, so bend the tip in the other direction. So now this is another case. We put an Evolut 26 in this patient, but after putting the valve, the patient became hypotensive with chest pain and EKG changes at the monitor. So these patients had undergone 6 months before to a PCR of left main. We did not check the coronary artery before TAVI. So we tried to engage with an EBU 3.5, but we were not successful, and then we used the 3.5, and we were more able to wire this lesion, which, as you can see, is very severe. There is severe restenosis of the left main, both towards LAD and circ. So we did stenting left main towards circ, and then kissing balloon. And this is the final result of this procedure. Now the patient is fine, he has no chest pain, and pressure is good. Amplas guides are very useful catheter because they allows you to perform a deep engagement, coaxial alignment, and this provides strong backup support. But you have to be very conscious because when you handle these catheters, because they may be really dangerous. And this is because the tip of the amplas points downward, increasing the risk of dissection. So do not force engagement when you use an amplas catheter, but you have to choose the proper size. If the tip lies below the ostium, that means that the catheter is small. If the tip lies above the ostium, that means that the catheter is big. So these catheters, the amplas catheters, are particularly useful in complex procedures such as CTO or calcified lesion or very tortuous anatomies. But they are also useful to negotiate anomalies of the origin of coronary arteries, like posterior and anterior left main takeoff, IRCA, or takeoff of RCA from left coronary sinus, or in cases of short left main with sharp angle for circumflex, or in cases of abrupt downward origin of circumflex arteries. It's important to carefully engage the coronary ostia when using an amplas, but it's important as well to learn how to disengage this catheter. So don't pull when you want to remove the catheter from the ostium of the coronary artery, because if you pull the catheter, what happens is that the tip will go downward against the vessel wall of the coronary artery, and by pulling you can really dissect the artery. So this is the correct maneuver. You have to push in order to move up the tip of the catheters, and then clockwise the catheter in order to disengage it from the coronary artery. So be careful when you use amplas catheters. So in choosing the proper guide catheter, you have to take into consideration two variables: the size of the aorta and the takeoff of the coronary ostia. So you have to combine these variables when doing the choice. And for each combination, there are several catheters that you can use. Don't be scared. You don't have to learn these tables. Your experience and your local practice which tell you which is the best practice according to you. Again, many catheters can do the same job, and you have to select the one for which you feel most confident. So let's start to simplify also this issue. So position 1 is where normally right coronary artery origin. Number 4 position is where the left coronary artery normally origins. Position 2 is the takeoff is a high takeoff for right coronary artery. In this case, you can use amplas left 1 or 2, amplas right 2, or an hockey stick. Position 3 is when the right coronary artery origins is posterior and in the left sinus of valsalva, near to the origin of the left coronary artery. In this case, you can use an amplatz left 1, 2, and amplatz right 2. But you may have also cases in which the left coronary artery is high and anterior. In this case, you can use amplatz left 1 or 2. So you see that for this situation, you can try different catheters, but you have seen that in each situation, the amplatz left 1 will nicely do the job in the majority of cases. So my advice is to try in this situation when you have to negotiate an anomaly or the origin of coronary artery. So first try amplatz left 1. So let's see these other cases. This is a young lady with pulmonary hypertension who came to our attention because of severe chest pain. And you can see that in these cases you have an origin of the right coronary artery from the left sinus of Valsalva. This is a Judkins 4, and you see that it goes near to the origin of both the left and the right coronary artery. But we were not able with this catheter to selectively engage the right coronary artery. Amplatz left 1 did the job. And then we did PCI of of the proximal part of the right coronary artery. Even with the amplatz left 1, it was difficult to engage the right coronary artery, and this was our strategy. So we first wired the LED, then we pushed down the catheter, directing it towards the RCA, and in this position it was much easier to engage the coronary artery. So we put wires just to have more support, and then we placed a stent at the origin of RCA. This is the final result. But after 6 months, this lady had angina again. This is the short axis view. And you see that there is a compression of the right coronary stent. This is the snake view in which you can appreciate better the compression of the stent. So again, you see also from the angiography that the stent is somewhat compressed. Therefore, we decided to repeat the procedure, and we put another stent inside. This is the final result, and after 1 year, now this lady is asymptomatic. So now, talking about all these issues, we have not neglected the fact that the majority of procedures are now performed through the radial access. And this is because there are also randomized trials that have shown that by radial access you have lower rates of complication as compared to the femoral access. The catheters, in fact, are the same. Here, the catheters are ordered in terms of support, from Judkins left to E-view to amplatz left, but for the using the radial, you have also specific catheter for this approach, the Icari left and the Kimi catheter. Also, these are the transradial catheters for right coronary artery, Judkins right, amplatz right, multipurpose, Icari left and amplatz left. Icari left is specific for the radial approach. Now, as the size of the radial artery is small, they have implemented this sheetless guiding catheter system, which is the EUCAT system. It's composed of a guiding catheter with the central dilator. It has an hydrophilic coating along its entire length and can be advanced along a 0.035 wire. So a 6-point French sheetless EUCAT catheter is smaller than a 5 French radial sheet, and a 6.5 French sheetless catheter is smaller than a 6 French radial sheet. So when you use the radial technique, you may have issues with the support, and there are some techniques that can help you in gaining support. For example, imagine that you have a CTO lesion or a complex lesion in the circ. You push the balloon, and as the force goes backward, and you disengage the catheter, the guiding catheter, from the ostium of the left knee. But then if you put a wire downward to the LED, you inflate the balloon, you stabilize the catheter, and now you can push the balloon and you may have chance to cross the lesion. So another way is using guiding extension catheter. We have basically two such catheter, the Godzilla and Guideliner. So in conclusion, the choice of guiding catheter is of paramount importance for the success of percutaneous coronary intervention. It must take into account patient anatomical characteristics and procedural complexities. In this regard, it is useful to understand the basic principle in designing guide catheters for specific requirement of the case. Thank you.
Dear friends,